right, so I am Dr. Minter, and this is Off the Cuff Nurses, where we're going to talk about all things correctional medicine and nursing. And I've got Dr. McConnell with me, who is my medical director at our local jail. Anyway, today we're going to talk about alcohol withdrawal. Why? Because it's important. So like I mentioned in the past, I do a lot of malpractice cases, and it seems like I've seen an uptick in alcohol cases, meaning bad outcomes for people that have an alcohol addiction and may or may not be managed correctly when they get to the correctional setting. So I want to talk about that because it seems to be a theme that, like I said, that's coming across my desk. So when you come into jail, we ask you whether you drink, and then whether they're honest or not. And we're going to get into that a little bit. We institute the jail that we're at institutes a scale. Now that's a national standard, is that you actually institute a scale. So the scale is called CIWA. It's CIWA, or depending on the jail you're at, it's CIWA-A. We're just going to go with CIWA. So it's clear as mud. So what does that stand for? That stands for the Clinical Institute Withdrawal for Alcohol. Now I had to write that down because we just call it CIWA. And CIWA means it's a variety of questions that we ask people that drink as to whether they're having symptoms of alcohol withdrawal. And why is that important? Because they can get worse. And when they get worse, bad things can happen. So, and I've had a lot of questions out in the community from attorneys in terms of what happens, causation. And I think that you're better at answering the causation part. So, for example, I'm going to start out. So, for example, we have a guy who comes in, say he's 40. I'm going to make it up. Comes in, he answers truthfully. He says he has, 12 pack a day. We'll just make it cut and dry. Yeah. It also depends on what EMR or electronic medical record you're using. Some of them trigger something to cause this scale. Some of them do not. The ones that we have, it does trigger for the nurse to do something about it. So they come in and they say they drink a 12 pack a day. So they clearly is probably alcohol dependent, drinks every single day. So he comes into jail and the nurses put him on the detox score. And it's got a variety of questions like hallucinations, which are kind of the worst, or shakiness, or all sorts of questions, nausea, vomiting, et cetera, et cetera. So they ask these questions and then they get a score. And when it gets to approximately 6 to 8, that's when it prompts the nurse to either call the provider, depending on the jail, or to give additional medication. So we give a couple different types of medication. We give us medications that are called comfort medications that kind of stops or quells some of the detox symptoms like nausea, vomiting. We give loperamide, which stops the diarrhea. Give Tylenol, which helps the aches and pains. We give Zofran for nausea. I think, is there anything else? And then we give for actual detox symptoms that are somewhat severe. That's when we go into the benzodiazepines or diazepam.
Yeah, part of it is, it can be hard to tell what people are detoxing from, because oftentimes people who come in, they're not only on alcohol, they may also be on alcohol and benzodiazepines like Valium or something like that for other medical conditions, or they may be abusing drugs and whatnot.
Right.
So, a lot of what we're looking at with the scores is not just for the alcohol. The comfort med could be taking care of withdrawal from opiates or other things, but those aren't as dangerous as the withdrawal from alcohol.
Yeah, so why is that dangerous?
So alcohol withdrawal, unlike opiate withdrawal, oftentimes, if it's severe enough, can have both the delirium, but you get the seizures. And when the status epilepticus, the seizures that don't stop, that can be life-threatening for people.
And when does So alcohol has a very short like clearance in terms it gets out of your system. Like methadone can take days or weeks. So alcohol can start at even 6 hours.
Right.
Right.
One of the things I would see in the emergency departments is, a nurse might see a patient and say, well, their blood alcohol level is still 140, so I don't think they're withdrawing. I'm like, yes, but their baseline where they live every day is 400.
400, yeah.
So there are guys and gals that might start withdrawing with alcohol still in their system. They're already getting, what we call the DTs, the delirium tremens. They'll get the tremors, the nausea, the sweats, vomiting. Ultimately, they can start hallucinating. They'll become just impossible to deal with. They're hallucinating, they're confabulating, they're giving statements, bizarre statements that don't make any sense, and then eventually we'll start seizing, and that's when you're in trouble. If you've got to that point, you've made it past trouble, you're in deep trouble.
Mm-hmm. Right. And I will say that this does not constitute medical advice. We're going to put that as a disclaimer, but we do have a lot of experience managing this, so that's why we're talking about it. So if we see somebody that's starting to withdraw, and the first thing that we do is, I think they used to give Librium, but I think there was a shortage of Librium, and a lot of the jails got away. They couldn't get it.
Yeah.
I don't know about the ER.
I will give it in the emergency department at times. I will usually go in and have a frank conversation. I'm like, look, are you interested in stopping drinking, or did you just run out of money, and as soon as we let you go and you get some more money, you're going to go right back to drinking? And if I see somebody that says, yeah, no, dude, I don't want to stop drinking, I'm going to keep on drinking. And a lot of these guys are honest. I'm like, yeah, no, I'm going to keep drinking. I don't want to quit. And I'm like, all right, I will give them, Librium. If it's somebody we're going to discharge, I will give them Librium and send them out, because we don't have anything to admit them for, or if they refuse to be admitted. These guys, they might want to leave against medical advice. And if they're alert and oriented ×3 and making sense and can make that decision, you have to let them go. You can't hold them, even though you know that they're on a road towards going into DTs. So, there used to be the thought process that if somebody's leaving against medical advice, you can't give them any medicine, but that's not true. So I will give these guys, Librium, we can give them a dose in the emergency department and then give them a prescription for it to hopefully tide them over until they can start drinking again. Mm-hmm. It's not ideal. It's certainly not what you want to do. You would love to admit them and help get them off the alcohol. But again, if these guys tell you that I'm just going to start drinking again, it's a waste of resources. You only have so much that you can do for so many people.
Well, not in jail though, because we don't have
jail.
alcohol.
We've got to get them off. Yep.
Jail, we have to do it. So, I mean, we have plenty of diazepam or Valium.
Yep. And to kind of give a brief idea, I won't use the technical everything. What happens is when you drink alcohol long term, it starts to deplete some of the certain neurotransmitters in your body. And eventually the alcohol, I don't want to say it replaces those neurotransmitters, but more or less that's kind of how it functions. And then when that alcohol goes away, that whole neurotransmitter system is thrown into disarray. It can't compensate, and that's why they start to develop all these symptoms, ultimately resulting in seizures, because they no longer have that system being running in the way it should run.
The issue that I've had is that, so I've had patients that I've given 10 or 20 of Valium, and I had one patient once that he swore he didn't drink, but he did. And I kind of knew it, treated it, but he was, I don't even know if he was on a scale. He was in jail. But he wound up, I had to transfer him to the ER just because, and they admitted him. So I don't know. So what do you do in the ER? Like if somebody comes in and they're in severe DTs.
If somebody comes in and they're actively withdrawing, we can do the CIWA scale, but typically if we walk in and they're shaking and sweating,
you know what it is,
whatnot, and we know that they're a drinker because a lot of these guys we know already. We'll start them on a Valium drip, and the answer is the question: how much Valium do you give? The answer is enough. If an or a benzodiazepine naive person comes in, somebody who doesn't ever get these medications, and you were to give them 20 of Valium, you might stop them breathing. Mm-hmm. You have somebody who comes in who's actively detoxing, whose blood alcohol lives at 500. 20 of Valium might slow them down a little bit, and you're just going to keep giving more and more and more. And there's other drugs besides Valium that you can give, but it can be whopping massive amounts that you have to give somebody to to bring them down.
Like what other drugs do you give?
You could do like phenobarbital or other benzodiazepines. You know, I mean, I've known of cases where somebody's withdrawing so severe they'll end up sedating them or even intubating them for their own protection and then sending them to the ICU. They're going to go to the ICU either way, but sending them to the ICU to be brought down. And the reason for this, and this is the same reason that people are in the same, you know, they have the CIWA for benzodiazepines.
Correct.
It's because at benzodiazepines, they work on that exact same neurotransmitter system that the alcohol is affecting. So essentially you're replacing the missing alcohol with the Valium or Librium or whatever it is. You're replacing those neurotransmitters with the medication that kind of bridges that gap. And then the goal is to slowly bring that medicine down enough while their body starts to ramp that system back up to working normally till their body eventually has made enough to take over that you can stop the medicine completely, or as the case may be, stop the alcohol completely.
Have you seen people like they've hallucinated or do they always seize or not?
It's rare. It is very rare for me to see somebody seize because, as I said earlier,
Stop it.
I'm way past the point of you're in trouble.
Right.
Especially if you're an emergency physician and you have not recognized it. I got bad news for you, bud. Now, for us in the emergency department, if we're seeing somebody seizing, this is probably somebody that they decided they were going to quit cold turkey at home without any family around, and then family came in, found them already at that state and has called 911 and brought them in, and the 911 for whatever reason didn't give them benzodiazepines because a lot of ambulances already have that stuff on board, so they might already be getting that medicine before they even get to me in the emergency department.
So do you find, because I've found that there's a lack of recognition for alcohol withdrawal, like it looks like something else, like it looks like a psychotic break.
That is definitely a big thing, especially the people who are, like I said earlier, the confabulating, they're just talking nonsense. It can look like somebody who's schizophrenic. And oh, by the way, oftentimes these people are drinking because they have other mental disorders. You know, a short aside, a story I remember at one of the emergency departments, one of our docs made a great call. They brought in this guy who was clearly very drunk and was acting bizarre. And he also had a fever. And the doc decided, hey, we need to do a lumbar puncture. And all the staff were like, he's clearly drunk. His blood alcohol is so high. He's like, yeah, but he also has a fever. I don't know why. So he did the lumbar puncture where they stuck the needle in his, drained the spinal fluid and found out he had meningitis. Come to find out days later when the guy had recovered, he had been drinking to try to make the headache go away.
Oh, yeah.
He was drinking to try to get rid of the symptoms of the meningitis that he didn't know he had.
Right.
And if this doc had just assumed, oh, he's just another drunk, what we talked about in that other episode with anchoring, if he had anchored on the alcohol and ignored that fever, this dude might have died.
Right. I had something similar like that. I was in college, so it was probably 35 years ago. I was an EMT in a college fire and rescue squad up in Vermont. And we got called to the local hospital. Guy was drunk, big, huge guy. I think we brought him in, and they backboarded him and collared him. And for whatever reason, this little tiny hospital just took him off the backboard and the collar because they said he was drunk. Well, he was drunk. Well, somebody did an x-ray. He had a broken neck. And what had happened was he had bone cancer, broke his neck, and he was drinking to try to get rid of the pain, you know. But what had happened, but they took him off the collar. And then they wanted us to come in to re-backboard him because, you know, that never should have happened. But, it was kind of the same thing, is that he was trying to quell the pain. Felt bad for the guy. That was a long time ago.
So when you're making your assessments, you need to remember, as the saying, there's a book called House of God, and in that book they say, the patient can have as many diseases as they want. Alcoholism might not be their only disease.
Right.
They can also be an opiate addict. They could also have medical problems that may be masquerading as withdrawal.
Right.
Or withdrawal that's masquerading as their other medical problems. So you want to be very thoughtful when assessing your CIWA scores and coming up with your number, and probably err on the side of caution to get the numbers. It is better to give somebody the benzodiazepine that they probably don't need than not give it to somebody who definitely needs it.
Right. What if you see somebody that's like, say they haven't admitted to alcohol,
right,
and they're whacked, how do you determine that it could be alcohol?
I mean, at that point, it's situational. You're going to have to look at the symptoms. And again, that's what the CIWA score is looking at, Oh, why are they so tremulous? They're shaking a lot. Man, they're in there just sweating. The guy's vomiting. You've done a urine drug screen on them, and the urine drug screen's clean, though that doesn't necessarily mean there's not drugs on board. But you have to use your clinical acumen, that knowledge you have as a clinician to recognize, wow, these are really checking all those boxes that say this could be alcohol. I need to start thinking this is alcohol.
I try to do the drill sergeant thing because the nurses will come in and they say, do you drink? And they're like, no, I drink once in a while. And then that may not trigger the withdrawal. But if they get me and I start seeing symptoms, I'll go in and I'll be like, how much do you drink? Well, how much do you drink? How much do you drink? And then the truth sometimes comes out before they're completely, hallucinating, preferably. So that will then you have more of a diagnosis.
What I will often say to people is like, look, I'm not here to judge you for drinking. I myself enjoy having a drink, and probably sometimes too much of a drink. So I'm not here to judge. Mm-hmm. I'm here to help you. Let me know. Tell me what you really do. Just like you said, you keep asking and trying to pin them down on something. And then you also have to remember, as I'm sure you see me say in emails or heard me say, everybody lies. Mm-hmm. And this person might be lying, and it's better to err on the side of caution than to find yourself past that point of no return.
One of the unfortunate things we don't have in jails, we don't have the advantage of collaterals. By collaterals, a friend of mine, a psychiatrist, and I, we do some speaking. Collateral information in terms of the wife, the daughter, saying, no, he drinks a lot more than that. We don't have that in jail where we can get that information. And that puts us at a distinct advantage because everybody lies, but sometimes the family would tell the truth.
Yeah. And that's in the emergency department in particular. I'll look around to see if I see eye rolls when they say, no, I just drink 2 a day. And I look behind them. And when I see the big eye roll, I'm like, really, 2 a day? I'm like, because I'm getting information that says that might not be the case. Yeah, you're not gonna get that in jail. The best that you'll get in jail is their past arrest record. Have they been arrested for this before?
Yeah, that's true. Yeah.
It's always look at the chart.
Right.
Take that extra 5 seconds to go, oh man, they've been here 10 times for alcohol in the past. And here's something that will get people in trouble. And I think you've probably seen me. I've said it in emails. I know. Oh, I didn't put him on CIWA or I didn't put him on any of these protocols because his urine was clean or his alcohol was clean. There wasn't anything there. And I'm like, remember, if it's clean, that means he has gotten to the point where it is out of his system and might be about to withdraw.
Right.
If you wait until the patient has gotten all of the alcohol out of their system, they're ripe for that withdrawal. And while we don't do the breathalyzer there, I guess, do we do the breathalyzer?
We don't do it for medical. They do it on the road.
Yeah. So, they may come in from the hospital, and it'd be a hospital return where they got sent there on their way to jail. And you may look at that hospital record and see, oh, there was no alcohol in their blood work. Yeah, but yesterday they might have been at 500 where they've been for the last 6 months. Mm. So you don't want to hang your hat on a lab test. Again, what I said earlier, if what you're looking at is not matching what you think it is, you need to reassess. Mm-hmm. If you're telling yourself this isn't alcohol, and that person who is tremulous, vomiting, not making any sense, and sweating profusely, you're setting yourself up for failure.
One of the things I've seen is that NCCHC, which is a standard for jails and prisons around the country, it's mainly jails run into this, is that they have a score. But I have seen jails that have a yes, no, yes, no, yes, no. Do you have a headache? Yes. Do you have... Without that objective score, the problem with that is that you can't quantify it and say, okay, at this number, call a provider right. or call somebody else. Not right. that it's, the end all be all, but when you have somebody who may be an EMT or a CNA doing a receiving screening, they don't have the medical background to really make that decision.
Right.
So, and that's a problem. I've seen that.
Yeah, the score is helpful because, like you said, it ends up giving you a number, you know, and if somebody's sweating profusely and they get a 7 for that, as opposed to just no real sweat at all and they only get a 1, I mean, that can make a big difference in where you end up with your final score.
Right. And it depends on who's scoring them too.
Correct.
So, you know, the guidelines are that they get scored once a day, the national guidelines. Most places score twice a day. I think they should be scoring twice a day, but it's just my opinion. But I will go in and rescore somebody, and I may get a much higher or different scale than the nurse is. Right. And it's usually I get a higher score. Yeah. So, but within that score is, you know, do they have beads of sweat, or, I mean, and all the, you know, the opioid scores are all kind of similar. And so there's a little bit of judgment there. So it may, you know, give you a 5 instead of a 4. So it's not cut and dry.
Yeah, and an unfortunate reality that you run into in corrections and in the emergency department is sometimes people get a little jaded. You know,
correct.
What I say all the time is, remember, these people are patients. These are your patients. You know, these aren't inmates. We're not here to make people suffer. We're not here to teach them a lesson. You know, we're here to take care of them. I tell that to the inmates when I talk to them, you know, and I refer to them as patients at that point, you know, and I tell, you know, the spiel I give people: we're sitting in an office in downtown somewhere. You know, I don't care that you're wearing this orange jumpsuit. I'm here to help you. Right. You know, whether they want to believe me or not, that's on them. And I say the same thing to you and my other clinicians and the nursing staff. Remember, these are patients. And I guarantee you, somebody you're taking care of here is innocent. Everybody is innocent until proven guilty. That's that's our law. But there are people that we are taking care of that are genuinely innocent, who were in the wrong place at the wrong time. You want to be, you know, even if you have trouble providing care for somebody because you're like, oh, I don't want to care for them because they did all these bad things. That's not your decision to make.
Right. You're working in jail, so
you're there
to take care of them.
You're there to take care of them as a person. You know, when it's funny, when everybody interviews for med school, they all say the same thing. I just want to help people. If I could give away my entire income to the poor to help everybody, I would.
I saw that on ER.
And the other. But interestingly, the jail does not have a line out the door of physicians and nurses, of people who are eagerly running over here to work so that they can prove that they just want to help people truly in need. Right.
What do you think kills people with alcohol, like withdrawal, when they're withdrawing? Seizures?
Seizures is generally what's going to get people. You know, they go into status epilepticus, they become hypoxic.
What is that?
Status epilepticus is a seizure that won't stop.
And what's the problem with that?
So when your body starts seizing, if you're having what they call a grand mal seizure, what happens is you have no control over anything. Your brain is checked out at this point. Mm-hmm. Oftentimes, these people will not be breathing, or they'll be breathing very ineffectively. And if they do that for long enough, their body is also, remember, it's shaking violently at this point. So all of their muscles are engaged. Mm-hmm. It's burning through all of their oxygen just as fast as it can. And then they become what we call hypoxic, meaning their oxygen levels start to drop. And once the brain goes hypoxic for even a short period of time, the damage starts. You know, with a stroke, which is another type of cause of hypoxia to the brain through a different mechanism. You know, there's a saying, time is tissue. And it's the same thing in a seizure. If somebody's, once their blood oxygen level is dropping, you know, time is tissue. That's brain that's dying. Okay. And if it dies long enough, they die.
What about, what about respiratory arrest? Have you seen that?
I have never seen it myself. But again, for us now in emergency departments, if you're letting them get to that point, you've waited way, 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 way too long. You know, like I said, I've not seen a respiratory arrest in somebody, but that's essentially what's happened. Because of their muscles and everything having locked up with the seizure, they're not breathing. So that would be it. Or
they could also, if they're older, maybe have a heart arrhythmia.
Yep, they can get into the heart arrhythmias. There's also, you'll have people who aspirate. So one of the things with status epilepticus is when people seize, they don't necessarily seize nonstop. You know, it could be a seizure followed by 30 seconds of no seizure, followed by 2 more minutes of seizure, and they just keep going right back into these seizures again and again and again. And that would then qualify them as status epilepticus, even though they've got these very brief moments of not seizing. And in that moment, they may vomit or something else. And then when they start seizing, they now start inhaling the vomit. And now it's in their lungs. and that's just doing that much more to stop them from getting oxygen into their bloodstream. So you have that. You can run into the fatal arrhythmias, like you said, where the heart goes into ventricular fibrillation or ventricular tachycardia, VFib or VTAC, causing them to have a death by that mechanism. Because oftentimes these people who come in and withdrawing are not typically your most healthy specimens.
Right. Yeah.
And again, you can have as many diseases as you want.
The most important thing, I think, is to probably be alert and recognize the issue, address the issue, and then if you don't know how to address the issue or if it's beyond your scope of practice, whatever scope that is, that could be anything from a CNA all the way up, then get somebody who can,
right,
or transfer them to a higher level of care.
Right. Just like I tell you in emails and in person all the time, I'm like, if you run into something that you don't know, my phone is always on. 24/7, you can call me or reach me and talk it over with me. It's better to discuss it with me and have my opinion weighed in on it than to blindly go out and knowingly, that would be that deliberate indifference, knowing that you don't know what's going on, but not doing anything about it.
Right. And wherever people are, there's got to be somebody that they can call or just transfer them to a hospital. So, and then that way, at least they're, getting the care. If the jail where you're at may not have 24/7 nursing or whatever else, but don't let it sit and don't wait until the next morning or whatever else to start,
right,
treatment.
Yeah. The sicker they look, the more often you need to be looking at them.
Correct. Yes. And frequently I'll write rescore CIWA in 2 hours after I've given them, say, diazepam. Because, if you don't, you can give them something, but then if they're not rescored for 12 hours, then what good does that do?
And that goes back to what we said earlier. How much do you give them? Enough.
Correct.
We have our protocols of how much we give, but if you rescore them and that number is still sky high, well, then you give more.
Well, but in jail, you got to watch the airway, though, too,
right,
because we don't have, we can't really intubate in
right,
jail. So that if it gets to that point, then that's when we're looking at.
Yeah, sending them out by EMS.
Correct. So anyway, so that's in a nutshell, CIWA or alcohol detox. Did you have any more comments?
Nothing I can think of off the top of my head.
Okay. So it's another podcast of Off the Cuff Nurses. I am Dr. Minter, and I've got Dr. McConnell with me, and we will see you next time.